This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 53 of the No Stroke Podcast. I'm Dave Dansereau. I'm here with my co-host Mike Garrow. Hey, Mike.
David, how we doing? Getting deeper here into Stroke Awareness Month. May 17th, we're recording this.
Yep.
So again, yeah, it's been a jam-packed month for us, though. A lot of great interviews we're getting out here.
Yeah, and we keep moving, fitting this intro in at our quick lunch break here. But yeah, tell me what's new with you before this interview went a little longer, so we'll keep the intro a little on the quicker side. But let's get caught up.
Yeah. Before we get into it, I mentioned a couple weeks back, had the opportunity to speak to a stroke support group here in Connecticut, Stroke OT, which past guest Dr. Caroline Brown is affiliated with. And later today, I'm going to be speaking with stroke support group from Yale as well. So they actually had a session a couple weeks back around podcasts. Their folks were interested to kind of learn what's out there and how podcasting works. So I'm excited to spend some time with them today and showcase some of our great episodes and kind of as I put this together, just, I think I mentioned it last time, just like the diversity of, folks that we've had on, topics, regions across the world, as we're jumping back over to Australia today with our guest. So yeah, looking forward to it. Always great to, have face-to-face time with survivors and caregivers.
Yeah, super. Thanks for doing that, Mike. It's really important. And again, it's, not everyone knows of podcasts as a medium for education. And as long as, we have the ability to do that. And we did a lot of it during COVID, but now this is a great opportunity to kind of expand the reach. So thank you.
Yeah. So yeah, let's get into this one. As far as we've going to touch on, obviously this guest today, as I mentioned before, is from Australia, Professor Julie Bernhardt. And we've had a couple guests on from Australia. Julie, is certainly Australia's leading researcher when it comes to stroke rehab, and has quite a international influence when it comes to designing stroke research and kind of implementing best practices as well from those research outcomes. So it was a conversation we've been looking forward to having ever since we got this confirmed a couple months back. But Julie, we had a great conversation. There's so much that Julie has done over her career, right? But we really focused this around some of the early research that has kind of gotten her to where she is today. When she was first coming out of school, going up to Norway, kind of seeing these early getting rehab started at an earlier phase of recovery, mm-hmm. Right? So fascinated to kind of hear her journeys, kind of, and what's gotten her today with her role as the co-lead of the Florey Institute for Stroke. And their focus is really on kind of designing this new frontier, not just stroke, but brain health in general, so multiple different conditions. But Julie and her team are really focused on stroke, looking to impact, that burden of disability in the post-stroke world, right? And it was, in the news recently, we speak to it on this episode, but they've just launched a new kind of hybrid service for young stroke survivors, really to identify and pinpoint service offerings for those needs of what we've discussed on many episodes, those unique needs of stroke, young stroke survivors, right? Returning to work, managing finances, things like that. So really, we love to kind of diving into that deeper, and looking forward to kind of seeing how this program scales and rolls out over the next couple of years.
Yeah, this was a great conversation, and one that, you know, adds to our growing list of accomplished physios, right? Like she's really doing some phenomenal work. I love some of the takeaways of not, you'll hear about not putting limits on stroke survivors in terms of when it, you know, finding that sweet spot or that entry point for where do you begin and what's the right time to begin. And she really put out a call to action, which you'll hear about, you know, for future researchers too. And I really feel this is where the future of recovery is going, and knowing, you know, there are biomarkers now that we can be diving into in the brain. And for everyone, you know, we talked a little bit, for everyone, it's a little different. We always bring back our training analogy from our athletic backgrounds, but that, you know, that pre-fitness level plays in, you know, how much do you hold back the reins? How much can you do? And, you know, there's just so many great takeaways from this, but, you know, I think that, you know, we could have, you know, I would definitely want to get her back on, because like what you mentioned in the intro, there are so many other great projects she's heavily involved in that,
and one of those particular, the International Stroke Recovery and Rehabilitation Roundtable Task Force, which, you know, has a multitude. One of our past guests, Dr. Nick Ward from the UK, he's involved in that. And yeah, I think where that conversation would be great to kind of go deeper on is, how do we involve the patient, or, you know, survivors, caregivers, those with lived experience within that model to advance some of the research and outcomes that they're driving. But yeah, certainly someone we'd love to have back. But let's get into this one. So without further ado, I'd like to welcome in Julie Bernhardt, you know, stroke researcher out of the Florey Institute in Australia. Hi, and welcome to the No Stroke podcast, Julie. It's truly an honor to have you here.
Thanks for inviting me.
Certainly. And I know you're a very busy woman, and, you know, we're really, you know, as we have now surpassed our 50th milestone of episodes, you know, when we think of people who have been as accomplished in the world of stroke, particularly within stroke rehab, that has been so involved, that we've had on the podcast. So it truly is, when I say an honor, it is an honor to have you here, and we're excited to cover as much as we can today. You know, there's plenty to cover, but for our listeners, I think it would be great if you could just kind of give a brief background of, you know, what's led you to your career here within stroke research, and really, you know, what motivates you to continue to do the work that you're doing.
Yeah, it's really interesting, isn't it, how we get to the places that we land. I'm interesting in that I didn't know what I was going to do, and about when I was 16, my uncle, who was 50, had a massive stroke. So I had this personal experience of stroke in my family, and I watched him go through rehab in those days, which is quite a long time ago. I'm 60 now. And I got fascinated by watching him recover, and that made me want to become a physio. That's sort of when I landed on, I'm going to become a physiotherapist, and this is really interesting, and that was my motivation. So of course I did physiotherapy, and then I explored lots of different areas, but I would say within 2 years, having done ICU and surgery and all of these different things, I just gravitated back to the brain. I gravitated back to neurology, and I've never left it. So the stroke, I think there's two things here. One, that sort of personal experience of stroke, and my uncle survived for 25 years, and so I had a lot of involvement with him in his recovery and his life. But also, it was super fascinating. If you think about this amazing organ that is our brain, that's so important to who we are and what we're able to do. And so the fascination has never left, but equally, I learned really early on what drove my passion for the area and my push to try and change things. And it was all about the patient. As soon as I hooked into that, for me as a value, it's all about trying to make a difference to the patient. Now, that was both as a therapist directly, but I saw this potential to do more for more people than the one-on-one as a therapist by taking this other path. And so that's sort of what led me down to doing more research quite early, actually, for physios, I guess, to get PhDs.
So that's so interesting. And Julie, thank you for joining us. Truly honored to have you here on the podcast. We want to dive into all the work and the great stuff you're doing, but we always start with when you're not diving into the brain and you're not working so hard. Just so our guests get to our listeners get to know you a little bit better. What do you like to do outside of all the work you do? What do you do for fun?
I like to sail. I'm a sailor. I've always been by the sea, and also I found, even in my incredible busyness, which I thrive on busyness, as you will be able to tell from the sort of scope of the things that I get involved with, but I find it incredibly relaxing, and it switches my brain off. So I'm all, when I mentor a lot of people, I'm all about helping them find balance. I think it's really important that you get balance in your life. You can't just work all the time. You need time with family, and you need time doing other things. And so this is one of my major sources of let go and relax.
Well, I mean, you're really selling the beautiful Australian coastline, and it's Melbourne that you're in, correct?
That's right, I am.
No, spoken like a true American, is it Melbourne or Melbourne? Melbourne, how do you?
It's Melbourne.
Melbourne. Okay, well, there we go. We're, as honored as we are to have you on, I will say that you are our fourth guest that's Australian. We've been privileged to speak with folks that I know you work with quite closely, both Dr. Stephen Davis, Jeffrey Donnan from the Australian Stroke Alliance, Kimberly Melkin from Angels Initiative, and an Australian removed here in the States, Dr. David Pollard, who is working out at Mount Sinai. And when you spoke to your experience, lived experience with stroke, Dr. Pollard had an amazing line, and we're excited to listen to yours around the magic wand question, right? Around how would you take that to redesign the stroke care pathway? Dr. Pollard had a brilliant line of, anyone working within stroke care, whether you're a researcher, provider, anywhere, any stakeholder, really to have had experience as someone, whether it's a survivor or a caregiver, right? Because you have that raw emotion, you really understand what what entails that day to day. And as you know, and every listener here, every stroke is different, but it goes to show how long that having that lived experience could take you in a career, and really bring you to a level where, again, there's a lot that we could talk through here, but you've been able to partner in with a group called the Florey Institute, and grow out their stroke and the early intervention program. So again, we do have some listeners in Australia who might be familiar with the Florey Institute, but I'd be curious, can you just describe, what this institute is, the magnitude of it, in terms of what they've been doing for brain science, and specifically to your role within the organization?
Yeah, I've been there for over 20 years, so I've had lots of different roles within the organisation, but the Florey Institute is a brain research institute, and it's both looking at prevention of injury, but also has nearly 600 scientists that are focused on a really vast array of brain injury or brain damage, so from lots of disease areas, but also, as I said, in the prevention area, and also looking at mental health. So we cover the whole kind of spectrum. Anything brain research, we're doing it. or trying to do it. I've been involved as a co-lead with a lovely neurologist called Vincent Tace, who's from Belgium originally and has made Australia his home. And we co-head the stroke team at Florey, and our researchers cover lots of areas. Secondary prevention, so preventing further stroke. We cover acute medical therapies with Vincent's work, public health, and our national stroke registry with Dominic Cadillac, some neuro rehabilitation and recovery work with imaging with Professor Leanne Carey and Kate Hayward, and myself. I've been really interested in thinking about how we might be able to help more people with stroke recover faster, better. And I, early on, after I finished my PhD, sort of hooked into this notion and some early evidence that if we could start the rehabilitation process earlier, we might have the potential to help more people reach their recovery targets earlier. And so that's when I started this concept of early rehabilitation, and it was building on some work that had been done in other countries, particularly Norway. They have a very active, or particularly one place in Norway, which is in Trondheim in Norway. And as a very early postdoc fellow, I trotted over to Norway in the midst of winter and to have a look at what it was that they were doing. And I've been working with them ever since, really. So they had this concept of this earlier rehab model that was really pushing boundaries, because what we used to do in acute care for rehab was very little. We would leave it to the doctors. And that's in recent history. So if I go back to the start of when I was first starting as a therapist, of course, I didn't see them. There wasn't a lot of therapy in acute care. I would see them in rehab. They would come to me in rehabilitation. Typically, and you won't believe this if you know the stats now, but typically patients would take 17 days to get into my rehab hospital, and then we would keep them for months as we would work through their recovery goals. Now it's like 5 days less in most hospitals, and in the US it would be very short. So this whole change has happened because we've got new treatments like thrombolysis and now thrombectomy. But it's really quite fascinating. So, but we don't have very organised acute rehabilitation. And so that was what the early rehab concept was. And I started looking at what was happening in our current care in Australia. So I spent a lot of time on my feet, observing around all of these hospitals. What was going on? What were the patients doing? Who was helping them? And from that work, I wrote a paper called Inactive and Alone, which is actually one of my most frequently cited papers, because people had never watched what happens to patients in hospital. We have this assumption that we're busy, so they must be busy. Well, that's actually completely untrue. So it was based on that we started to think about, how do we build an intervention that might build in appropriate rehab early? How do we implement it? How do we test it? And so I've spent a lot of time doing clinical trials, and in keeping, I think, with my other passion, which is collaboration, and collaboration outside of my own space. I like to collaborate with people from lots of different disciplines and backgrounds. And I also like to always involve stroke survivors in my research, and I've done that throughout my career. You know, we've sort of built these studies and run them in multiple countries, and so that's what one of my things I've been occupied with for a while.
All right. Well, thank you for that overview, Julie. And fascinating to hear, you putting your boots on the ground in snowy Norway. Although it is a beautiful country, I have to say. I have
Yeah,
a friend in Oslo. But you were able to really experience this, and I'm fascinated to go in and read that paper, because when you describe inactive and alone, right? Like, I mean, that's the complete opposite of what stroke survivors need, right? It's stimulation
right.
and activity, right? So, with this learning, obviously, you then took this back and really started to think about how we get intervention earlier in that rehab process,
Right.
which is super complex. But it's kind of led you to another large research paper that you're working on. And speaking of being collaborative, it's kind of one of the first trials, from my understanding of its kind, where it has multi-centers, and you could explain kind of the design of it, because I surely don't have that level of detail. But it's around the AVERT dose trial, right? So,
Yep.
can you explain again the aim of this study and kind of its ongoing research?
Yeah. The AVERT dose trial, I'm calling the final trial in the series. So I'll take you back one step, which is to the AVERT trial, which stood for a very early rehab trial. And that study was done in 56 hospitals across 5 countries. Doing international trials is really challenging, but also really rewarding. And you're right. In fact, the AVERT trial, which had 2,104 patients from 56 hospitals, is still the largest rehabilitation trial in stroke ever. And it took 8 years to complete that study, because we didn't have a network of centres that were used to doing rehab trials, unlike trials of thrombolysis, the clot busting drug, or trials of thrombectomy. The doctors are very well organised in collaborating in those kinds of studies. It's still really rare in rehabilitation for us to have studies that go across multiple centres, even within a country, let alone studies that go across country. I really want to encourage more cross-country studies, but in saying that, it's not easy to do, because there are so many regulatory differences across different countries. But boy, you learn a lot, because the health systems are not the same. And so AVERT, we pushed patients really hard. So we did a trial that was comparing a lower dose usual care intervention to a much higher dose intervention that was delivered by physiotherapists or physical therapists, as you say in your part of the world, and nurses. And they worked together to deliver this early rehab intervention. And it was dictated by the functional status of the person. So as you saw them in front of you, you would work to align your therapy to their need. And we ran that study to its final end, and that finished in 2015. But unlike what everyone expected, which is that this early, really intense rehab would show benefit, we actually showed harm. Now that freaked everybody out for a while, until they except our investigators. In fact, our investigators, so all the therapists and nurses at the site said, "Hey, Julie, don't worry, this is really important information. It's showing that if you do too much too soon, it can be a bad thing, not a good thing." So it shatters the assumption that more is always better. Now that's absolutely fab. It's a good outcome for us. It creates a nuance, something that's important for us to keep exploring. So while we finished the AVERT trial, I thought, okay, we've got this other study that needs to get done, and that's why AVERT dose is in the final study in the series. Now, AVERT dose is different. as a trial. It has taken the learnings from our previous study from AVERT. It's removed, we think, the doses of training, so how hard someone's working, how long, how often, and we've taken the ones that cause harm out, and we were left with at least 3 different combinations of mobility-based therapy. And rather than run a study that was just like 2 parallel arms, which is what you normally see in randomized control trials, we've done a different design. And this design is called an adaptive design, which means that it's a response adaptive design. I'm not going to go into great technical detail, but basically it means I can put forward 4 different doses of intervention, if we frequency, amount, and over time, as the study runs, we take the outcomes of people and that gets fed back into which arm of the study the patients go into. So over time, we hope that we'll find the best intervention, the optimal, and that the other study arms will shut down. And that's why it becomes a much more ethical, efficient. So we're not going to put people to harm, because if there's a bad outcome happening, which there shouldn't be, because we think we've got rid of those very high doses, then we'll know and they'll close. So it's a really interesting approach. And I think it's the first rehab study that's taking this adaptive approach. And I'm really proud of that. It's in 7 countries.
No, it's very impressive. Curious, how was intensity measured when you, was it volume based that you measured and said the intensity was too great just based on volume, or was it down to the individual? How did you quantify that?
Yeah, I think that is a good question, and I need to be clear. When we talk about dose, has lots of different parameters.
Yeah.
We talk about frequency and amount from AVERT. We do say too much too soon, but it's too frequent, too high an amount. Now for AVERT dose though, we are specifically also asking therapists and patients to rate intensity. Intensity is how hard someone is working. Now, we did rate this in AVERT. We actually asked every time a patient completed a treatment what their perception of the intensity of the treatment was. We have all that information from our previous trial, but do you know what's really interesting? And David, you know, with your physical therapy hat on, it's really interesting that stroke patients sometimes don't perceive that they are working very hard when a person who is standing in front of them is seeing them sweat and have their heart rate up, and they'll say, oh, it's about a 5 out of 20 on a Borg scale. You might know what that is, but it's just like, oh my goodness, to me, you're working really hard, but they don't necessarily perceive it. So we are measuring intensity again in this study, and we're measuring it from both sides, from the patient side and from the therapist in front of them side. It's actually super interesting, that bit.
Yeah, and it's funny you say that though, right? Because it's often you'll think of, stroke survivors in a setting where, they know they're not the same as they were, right? So they might have that kind of, tendency to say, oh, it wasn't too tough, right? Just because it's like that psychological barrier that they're trying to overcome as well. Yeah, and it's interesting, so one thing, David and I always talk about on this podcast, it's, post or stroke rehab is like training for the Olympics. So like training like an athlete, right? And it's interesting, like, we've spoken to stroke survivors who, one gentleman who came on recently, he was quite fit before his stroke, right? And that was a huge benefit for him in his rehab, right? He had
Right.
the understanding of like, obviously, exertion and kind of bringing you to that point, but fortunately, so many survivors don't like have that experience possibly prior to their stroke, where it almost, as you were describing this, it reminds me of like, you know, I was doing CrossFit years ago, and it's like you get thrown, you get thrown in a, like you haven't worked out in 20 years and you get thrown into a CrossFit class and you go and, hurt your shoulder because you're trying to do some crazy lift. So with this, you mentioned like you've scaled to like specific exercises. Would it be the same sense of being like, all right, you're taking out these crazy Olympic lifts and you're doing like a squat and a push up and a, shoulder press or something? Is it similar in terms of like what you guys are now scaling down in terms of exercise for this?
That's a good question. When you were speaking, it made me think of one of my pet hates as well, which I'm going to share, which is watching therapists put limits on patients. So you must be tired, have a rest, not watching what the patient actually is doing. Or, I think we absolutely underestimate the challenge of the rehab process for an individual. So what it must feel like to them, and people need to ask what it feels like to them, but also what they actually can engage with. I really hate to see therapists putting limits on this. Oh, you've done 10 repetitions, so just sit down and have a rest, when the person might be absolutely ready to keep going. And to your point about someone previously being fit, I've heard stories from stroke survivors where the therapists just weren't pushing them, weren't letting them try and get back to cycling because, oh no, you're not going to be able to do that. Well, and they just set their bike up in their corridor and every day would sit on their bike with a stationary wheel with the wall either side to keep them safe, and just kept going, right? And I think it should not be therapists who put limits on patients. This is one of my absolute sort of pet hates. But there are a couple of things there that I will come back to. One is your question about how do we progress and what is it that people do. So in acute stroke, I still get quite criticised for trying to start rehab interventions really early after someone has a stroke. And in our first study, we started within 24 hours of stroke onset. There were a lot of people saying, just leave them alone. No one needs to start doing things so quickly. And the biology is really interesting. We actually have very little information about brain biology in terms of when the brain might be ready for rehab in humans. What we do have is some biology from rodents that suggests that there's a window where they might be quite vulnerable first after their stroke, and then it becomes better because of all the cascade of effects that's happening with the brain injury to start an intervention. But I'm one of those people that's always asking, but why? So in the animal studies, they definitely show that if you start earlier rather than later, like 5 days versus 30 days, then you get a better outcome for the rodents. They'll recover faster if you train within that sort of earlier time point. And all of this was pointing to me in the right direction for us to do this in humans. And then you have people saying, but you shouldn't start within 5 days. And my response now to that is, people are only in hospital for 5 days. If you don't do anything for 5 days, then you're actually keeping people resting in bed. Resting in bed comes with its own harms. So I say this because what we've got is this delicate balance between starting and not overdoing. And in reality, we actually don't have the science that we need to know when a brain is ready. I keep talking to young people about this now because I would love some of our young clinician scientists and scientists to be working towards some markers of readiness for rehab in the brain. Because readiness for rehab in a person will vary from person to person because of their personality. You've given an example of someone who was previously fit. They were probably ready to hit the ground running, so long as they didn't have extreme fatigue and so on. But wouldn't it be amazing if we could know when individuals' biology had settled enough and they were in this responsive state to go, right, guys, now it's time to really hammer your system because your brain is optimally ready for us to try and make these recovery connections and improve and accelerate your recovery. That's what I would love to see happen. That's what I hope people will keep working towards. So for us, what we do is we are a bit gentle early, coming back to your question, so I won't forget. And that is, but we get people up. Now, again, that was very controversial to start with. So we get them up out of bed. We get them standing upright. And then over the course of the first couple of days, we just start to progress that. Then once they get to sort of day 3 post-stroke, which might only be a day after we've started working with them, by about day 3, we think we're pretty safe. And then we start to go, right, let's keep going up in intensity. And for every intervention, the therapists and nurses are trying to take it up to the next intensity, and they just monitor the patient to see if they're able to do more. And when I say intensity, David, I really mean intensity, as in we're monitoring that how hard that person is working, and we're trying to take them up a notch into how hard that person is working. So it's super interesting because the other thing we're doing is we're limiting how long that intervention is. So when we say, look, you've got 10 minutes with that patient, that means 10 minutes on task, not 10 minutes to have a chat. That's 10 minutes for you to train. And then the therapist said to me, oh, well, that's not long enough. And I said, hey, guys, come on. I could get someone working extremely hard for 10 minutes. Even you, if you had your personal trainer getting you doing something for 10 minutes, you would be absolutely exhausted. You can do this. That's what we're aiming for.
Yeah. And that's the creative spark that I think the PT should be bringing to that. Absolutely. But you bring up so many good points, and in trying to find that sweet spot initially, you brought up a good point. Like we're not going to let an orthopedic patient stay idle just for in the hospital for 5 days because of all the other risks that happen. So back to Mike's point about like this, in trying to find that sweet spot of when it's okay to start progressing, and I'm hearing it's kind of like if we had the ideal way to look at certain maybe biomarkers or what.
Correct.
It's because like that fitness level that we talk about, is that sweet spot maybe accelerated by a couple of days for someone who previously may have had a foundation of fitness. And like it has to it has to be individualized, but I totally understand like how like you conservatively want to hold back the reins, but if they're ready to go, it's like let them go. And after you get that you see what their baseline is, and then you take those 10 minutes, and yes, you can do a lot in 10 minutes creatively. Absolutely.
You can. Yeah. I think this stuff is super interesting as well. The previous fitness piece, and also previous brain health, and even there's, and we're collecting some of this in this next innovate dose. So I would, you'd be surprised to know, I think, that I gave a talk it must be at least 10 years ago, they asked me what pre-stroke physical fitness had to do with post-stroke outcome. And I went, that is such a good question, because I've asked it myself, because I have a patient in front of me and I see this variation depending on their fitness. But let me go back to the literature. Could I find anything on this? And that's what sort of took me down a path of doing some exercise work for quite a few years. But now we see that there's a lot of studies, their association, which you'll know is just, it's a big data set, and you look at relationships between something and something else, and it's not causal. But I tell you, the evidence now is that if you are physically active, not athlete, just physically active prior to stroke on a regular basis, it does two things. It both actually makes the stroke less likely to be bigger, so it can reduce the severity of stroke, which is great, but also it can improve the final outcome. So the recovery profile and the stroke itself seem to be impacted by the physical fitness and the physical activity that a person has prior. So these are actually really important things for a therapist and others to put into their thinking caps when they have a person in front of them. Do not, and I'm with you, David, don't hold them back. If someone has that and they can go, let them go.
And I think that leads perfect into what we'll look to talk to more specifically after the break is, the population who might be at a slightly greater benefit to come in fit, right, is this younger cohort of stroke survivors, and unfortunately, a cohort that we're starting to see more of starting to have strokes. So we'll jump into that right after the break.
Great.
Okay, and we're back. I feel like we have so much still to cover, and I really want to make sure, I know this is an area that's dear to your heart as well, Julie. I want to talk about the unique needs of young stroke and what you're seeing in your work. I guess the first question to ask is, in your opinion, have young stroke survivors received enough personalization in their care and, defining specific research or rehab pathways that those unique requirements deserve? We often say other conditions have that more, dedicated follow through over the lifespan. And when it comes to young stroke, and we've had many guests on that are, one that's always resonates to me, like when one of our guests echoed the sentiments of a stroke survivor, felt like they were life flighted into the hospital and got the best care there, preserved as much brain as they could, and then they got home and they were like, they used the analogy, they were dropped out of the helicopter again without a parachute.
Right. And the short answer is absolutely not. Do we have good services for young people? Even in your country, I believe there's only a couple of places that they're starting to pay attention to young people. It is remarkable what is lacking in this area. And I think you brought it up as well, Michael. Yes, increasing number of young people having stroke, which is pretty worrying. But yet, while some of those people might be having a stroke because they are increasingly having risk factors similar to older people, there's still a lot we do not know about why a young person has a stroke. And that in itself is a huge gap. But we have always been really interested in younger people, and I think there's a couple of things here that are really important. One, and you mentioned it before the break, Michael, and that is that we assume that young people will have a better recovery. Well, in making some of those assumptions, we don't give them any services because we assume that they can have better recovery without us. This is criminal, I think. So if you have, and we've shown even from our data from AVERT, where we followed a young cohort in the trial and looked at what their pathways were, there are a lot of really young people who had no rehab whatsoever. And at 12 months, their outcomes were very poor. Depression, problems with finances, poor quality of life. So I feel really strongly that it's time for us to create services that are dedicated to young people. And that's what we're just embarking on here in Australia. We've just had some funding from our government. It's $10 million. It's significant, but not enormous, but it's significant. And it was given to us and our team. So it's not just people at Florey, it's across 2 states of our country. We're trying to show that we can build a service that has dedicated attention to young people with stroke and that uses the digital platform to help connect it all up. So the service is hybrid. It's both in person, it's tele, it's tackling some of the real areas of unmet need. And that's what you were touching on, David. There's a lot of unmet need for younger people. It really attacks, as you know, a person at a point in their life where it's so disruptive. Work, family, study, life, relationships, peers. And of course, we know that a lot of young people lose relationships. They get really disrupted. They become alone. Relationships sometimes don't survive a stroke. And I think it really is beholden on us to take some time to build these services. So just on the unmet needs, what led us to creating this service is that we started doing work on what are people's unmet needs, and then we created a tool, an unmet needs screening tool, which we created with young stroke survivors. We do pretty much everything with the stroke survivors. That's one of the strengths, I think, of our research program. And when we asked them, then we tested this. This was published in Neurology a couple of years ago. We tested the unmet needs screening tool, and it exposed a lot of areas where people needed help. And from that, we decided that would become the basis for our therapy and sort of our recovery program for young people. So now what we do is we're building this platform where people can come into the service, and they can come from anywhere within the state of Victoria, anywhere within the state of South Australia in our country. Into the service, they complete the unmet needs screening tool, which they select their top 3 unmet needs, because we can't deal with everything all at once. And then we're going to create these pathways for people to help support them into this next phase of their life. And often the things that are missing are help with getting back to work or study, help with navigating the sort of financial consequences and support needs, psychological support, and also a lot of young stroke survivors have problems with memory and cognition after stroke, and they really want help with that too, because it has a big impact on their life. So we're starting with those things, less traditional than sort of more PT or more OT. We're actually starting with the need. And as over time, we're going to follow these young people every 6 months for the first 3 to 5 years after their stroke. And we hope that they won't feel like they've been dropped out of an aeroplane without a parachute.
That's super important work. And I love how many times you've kind of iterated the fact that you've designed both research and some of these programs with survivors, right? It's the utmost importance, and also caregivers as well, right?
Right, completely.
So I'd be curious, like, with obviously this funding just coming in and kind of things getting off the ground here with the design of this, how early in the rehab process would you expect survivors to be kind of enrolled in a program like this?
So we are treading this really interesting line, which is not wanting to duplicate care, but wanting to value add. And what our young people say is they want a one-stop shop for things. Don't send me to 17 different places. Just send me to one place. And then maybe they can coordinate and help move along. So we are taking people, they can enroll and be referred by anybody who's a health professional, not just a doctor, at any time after they've probably left hospital, right? Because they're having their care in the hospital, whether they're having acute care or rehab care, they can come on as soon as they're referred, because we'll then start working with them with the other unmet needs. We also want to make sure that we're not, as I said, we're not trying to duplicate an existing service. We're trying to create something that's that fills these gaps that we know currently exist.
Is that Julie, where the digital connectivity, you said they're looking for a one-stop shop. They don't want to have this fragmented, more silos. Is that where the power of that comes in?
I think so. And as we work with survivors and carers, we're also contemplating things like having a space in this platform where people can store their own information about tests and care and so on, so that they can share it with other health providers and have it accessible. They can control who gets to see it. And while we are asking people to give us information on person-centered outcomes at certain points in time, because we would like to be able to track whether this is actually helping or not, we have an objective that everything we give back to people is theirs, and it's written in a way that they can access it. So we actually have an amazing team of people who are also trying to make sure that the platform and all the information that we give and to people is communication accessible, even if you have aphasia or cognitive problems.
Sounds like, an amazing opportunity here to really make the difference that survivors are asking for in carers as well, right? And you mentioned the initial funding coming in from the government, I believe. Is that the backing?
Yes.
So if you had to kind of think longer term and how this service could be implemented, and obviously you mentioned, right, like going back to even your collaboration with services or research across different countries. Every healthcare system is different. Every healthcare system is funded different, right? And that's the ultimate elephant in the room is kind of a service like this. How do you envision it being reimbursed?
That's a great question, Michael, and something that we've had front and center from when we started writing the application for the project. Sustainability in healthcare, such a biggie. And isn't it terrible when you get innovation that happens and then nothing happens with it because no one's going to fund it? It's just a waste. I just find that I get despondent with that stuff. So we are absolutely thinking about this. If you're going to get sustainability in healthcare, you have to have, I think, and especially with the technology platform, you have to have a couple of really key things. You've got to show that it works for the users. So is it actually creating benefit for them? So we've got to have evidence. We have to have evidence. We've got to have evidence from consumers, which is stroke survivors and their carers. We've got to have evidence from the clinicians that it actually makes a difference as well. So we've got to do research there. We've got to get information about the cost of the service and how it might compare to current costs. And we have to make sure that the digital part of it is sustainable. So it's not going to become redundant in 5 minutes, but then I reckon while we as researchers and clinicians can set this up, it's really a lot of change, and you would have seen this yourself, actually happens because you have advocates like you guys who are pushing for something. There's a famous quote from a good friend of mine that is, we can do all the science we like, but it's usually with politicians, it's an N of one. It's a personal story that starts to get them on board. So what I would say is I think we all have to work really closely with stroke survivors and their families. They're the voice into politicians, and I think you were quite right, David. It happens in diabetes in our country. There's a specific service for young people with diabetes, young people with dementia. It's like a handful of people. Not saying it's not terrible. It is terrible. Young people with cancer, but not young people with stroke. And yet we have a huge group of people who have a stroke every year who are young.
Yeah. And I think that enough of us stand up and raise our hand and say, this is not right. And we create that ripple. And just from the conversations we've had now, as Mike mentioned, we're over 50 in. The more connections we make and the more stories that resonate and we share, and the great work that's being done with groups like with the work that you're doing, that I'm optimistic. I feel like there's so many people doing good work, but we have to kind of like all throw rocks in the water, all stand
one
up.
of the hardest things to do. It's like change management,
Yeah.
right? And it's one of the hardest things to have to do, in the corporate world, no matter where you are. It's that perception of what stroke is, and it's moving from being, a debilitating disease to something that has hope, right? And
Absolutely.
Yeah,
absolutely. And that's what we're hoping the International Stroke Recovery and Rehab Alliance will do, and that is, we're very optimistic. This is our new alliance. We have nearly 500 members across the globe in ISRA, and our mission is to create a world where global collaboration leads to breakthroughs for people with stroke. That's our mission, and we really want to see these collaborations around all of this stuff, both changing healthcare systems, but also around finding science that's going to really game change care, whether it's the biomarker piece that I'm banging on about, or whether it's a new drug or something that's actually going to really help recovery. That's what we need to be doing, because stroke is such a fascinating condition in that it's so important and so common, and yet it's really hard for us to get traction for some reason. And I've never really understood that, because of course I'm deeply passionate about it, and I reckon all the metrics are there to say, come on, let's get going and do some really radical stuff. But anyway.
Well, maybe you could take the magic wand and say, if there was this huge change where, stroke became front and center for everyone, and you could have this magic wand to do whatever it is to redesign the stroke care pathway, what would that look like to you, Julie?
It would look like we knew and personalised our treatments for everybody who had a stroke, rather than giving everyone the same thing. Which is okay, but it's not good enough. So if I could wave the magic wand, I would want that discovery, and from that discovery would want to optimize recovery for everybody. Now, if I just think about now, what I would love to see with what we know now is that everyone who wants rehab gets it, and everyone who leaves hospital has that thread, that support system in place so that they can manage and take on the rest of their lives feeling supported. Because I don't think it helps anyone to only think about rehab as just a bit of care that happens in a hospital. That's nonsense. That's just trying to set people up for success. But so when I talk about everyone who needs rehab gets it, I don't mean just in a hospital. I mean everyone who needs rehab gets the support they need for their recovery to keep going. Because you know, and I know, and lots of your previous speakers would have said that recovery keeps going for years, not months. And so our big challenge is creating a new health system where that is the reality, and that it is not just front end loaded to the point where people just get dropped as soon as they leave a piece of physical building.
That's when the recovery journey just begins, and that's
correct.
where, yeah. So
Correct.
well said. This is, I feel like we definitely have to have you back for a part 2 or more. I'd love to see that happen. I know you're really
Nice.
busy, but I feel, as we said at the beginning, very fortunate to have you on as a guest, and I think this is going to be a great episode to share with our community. So we thank you for your time and your wisdom today.
Thank you, David. Thank you, Michael. As you can tell, I can talk about this stuff for hours. Just ask me anytime.
Thank you again, Julie. It was a pleasure. And best of luck with everything. I'm sure we'll be having you back soon.
Lovely.
Thank you.
Have a great day.